So we're going to do a 5-step analysis. When you think of something you want me to explain, just tell me and we'll get it explained, all right? But it's basically identify the rate and the underlying rhythm. Why do we do that? Aren't we looking for ST elevation? Don't we want to know a STEMI? Why are we looking for rate and rhythm? Patients shouldn't die while you're reading their 12 lead. Yeah, well, it is. And that's kind of like shocking them into asystole because I know how, that's my rhythm, I know.
I know that one really well.
Yeah. Epi, 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 epi. Yeah. Lots of help. Okay, so identify rate and rhythm. Fix it if you need to so they don't die while we're doing the rest of this. Okay? Seriously. Whoops. That's right. Then we're looking, number 1, for pathologic Q waves. What's pathologic? 1 little square wide, 1 little square deep. At least that much or more. Okay? Then we're looking for ST segment elevation. I told you how to do that. We got the QRS where you quit measuring the QRS. That's the point that we're looking for the ST segment. We also call it the J point. We'll look at a few of those. Look for ST segment depression. And by the way, you're counting the little boxes whenever you're looking for elevation. And only a full box is worthwhile looking at. All right? Then ST segment depression, we're looking for tall peak T waves and inverted T waves. Okay? Now, I can't remember all of the formulas that go with inverted T waves, so we're not going to do that very much. Okay? You might. If you do, I'm happy for you to talk about it. All right? For you to talk about it. And now we look for evidence of infarction, so a suspected STEMI and its location. So when we're trying to figure out the location, what do we look for in the elevation? That the elevation is in what kind of leads? What's the word for them? Contiguous leads. Contiguous. And it just simply means that they're leads that are sitting beside each other electronically looking at each other. It's the one next to each other all the way around. Okay? I'm also now in step 4 going to look and see if there's any imposters. So here's the list of imposters, and then you have to know how to work each one of them, right? LVH, left bundle branch block, ventricular rhythms, benign early repolarization, because what that means is the T wave's too close and a T wave got involved in the QRS and it looks like a ST elevation, it's really not. And pericarditis, all right? And that's the one we kind of forget sometimes. And I've got 1 or 2 of those. Then make a decision. Is something definitely not a STEMI? Now, can I say that they're not having a heart attack? If I say they're not having a STEMI, can I say they're not having a heart attack? They could have a non-STEMI. Well, if there's a STEMI, there must be a non-STEMI. And that's exactly correct. Nobody should be telling someone you're not having a heart attack. Okay. 50. Ish. Yeah. Yep. Yeah. A suspected STEMI and then a definite maybe. Okay. I don't care if you use those or not. But that's how we'll talk about them a little bit. So what I'm going to do, we're going to skip a bunch of them, and I don't have them all blanked out, so we're going to have to go through a couple till I get to the next one. All right? So, but we will look at the first one. Not good, right? I think so. All right. So which leads have ST elevation in them? So definitely 2, 3, AVF. What about V5, V6? Okay. Now, reciprocal changes, meaning ST depression. Which ones have that? AVR does. I'm going to tell you, we really kind of do 11 leads for the most part, but sometimes when AVR is involved, it just means it's that much worse. Okay? AVL, definitely. V1, V2, right? So what did I tell you about V1 and 2? If they have depression. That it might also be a posterior. It might also be a posterior. Well, I have the inferior. I know I have an inferior. Do I really care if there's a posterior now? Maybe not, right? I really don't. So you can spend some time thinking about that, but I'm not going to worry about it. What do I want to do with this 12 lead though? 2, 3, and AVF are elevated. Tell me what part of the heart that is. Oh, wait a minute. There's cheaters down here. Okay. See 2, 3, and AVF? What lead is it? Or what part of the heart? Inferior. So the bottom part of the heart looking up. And B5 and B6. So it's an inferior lateral. We could call it an inferior lateral. When you call to the hospitals, do you call and tell them they're having an inferior lateral? They don't like that, do they?
No, then they start with the what leads are doing what.
There we are. So just start with what leads have the elevation in them.
2, 3 AVF is elevated.
Yeah, 2, 3 AVF and V5 and V6 are elevated in this one. Absolutely. With reciprocal changes. Yeah. And if they really want to know the reciprocal changes, I guess they can ask, and I'll tell them. But I will tell you that I would recommend on this patient that I do a V4R, at least a V4R. Again, I don't really care if you do 8 and 9. Why do I care? If I don't care about V8 and 9, why do I now care about V4R? Huh? To know if it's the right ventricle. And what's the problem with it being the right ventricle? If the right ventricle's involved, does it change my patient care?
Yeah, you don't pour nitro to them.
No nitro, not without lines anyway. It depends on their blood pressure a little bit. But be careful about the nitro and be sure that you have a good strong line in them, if not 2, so that you can pour some fluid in them. Okay, so now we accidentally or we just missed the fact that 2, 3, and AVF, I shouldn't have given them nitro. We pop a nitro in them, or they take it themselves before I get there, right? Because that will happen. They take it themselves before I get there, and they fall down on the floor, right? How do I fix low blood pressure for a person that we gave the nitro to? We do pour the juice to them. What else do we do? Just make them flat, okay? The blood will pool, and it will get back to their brain if you make them flat, okay? So make them flat, pour the juice to them, do all these things, right? And don't give them another nitro. Okay, stop with the nitro now. All right. Can I give them aspirin?
Yes.
Absolutely. Absolutely, I can give them aspirin because that's just going to help break up the clot or prevent it from getting bigger. It is not going to change the size of the vessels. Nitro expands the size of the vessels. Okay? All right. There's your next one. I told you I was going to have to jump through a few. Rate and rhythm. Okay, so the bottom of this, they actually have a 10-second strip because that's how long. Now this is V1, right? So it's looking from right here. It's V1, so you have a 10-second strip of that. So here's another key that I want to be sure you understand. Time is measured this way, and this is, we do not have these two that are duplicated here and duplicated here and duplicated here. That's not what happens. This is one continuous lead here, or one continuous reading time-wise that is changing leads. All right? Time is marching on and it's just changing where it's looking from. We're looking at 3 of them at a time. If I had paper wide enough, I could do all 12 leads at once. That's kind of cool, right? I could, because the machine will do it. We just don't have paper. That's just silly to make paper like that, okay? But we could do that, because it only needs to look at 1 beat in each lead. That's really what it's doing. It's going to pick a beat in each lead, and that's what your monitor is running off of. That's why sometimes you don't agree with your monitor. Well, it's okay. You shouldn't always agree with your monitor, and you shouldn't always go 100% with what it says. I want you to make your own decision. You can look at it and see if you think it saw something you missed, or if it thinks something else. So you just got this thing back here that goes, oh yeah, I missed that, or no, it's crazy. I'm going with what I know, because we're smarter than the machine. The machine's only as good as what crap's put into it, okay? So this beat is the same beat as this one, that's the same beat as this one. You're just looking at it from a different point of view. These are all the same beat that are the same as this one. And this one is the same. So can you imagine if we put a PVC out here someplace that I wouldn't know, God, what the heck is that out there in the middle of this thing? Well, that's the reason that we have this 4-channel thing. Because I got one running across the bottom that tells me what a single rhythm is all the way across. I don't care if you do V1 or 2 or exactly what you do. Do you know you can do that with our monitors?
No.
You can, okay? We're not doing that today. The LifePak 15 will do that. Yeah, I will show you. Yeah. That's a one-on-one thing, yes. There's a lot of fun things our packs will do that we just don't remember. We've been maybe shown once. Well, why would I remember that? So, all right. So, is the rate and rhythm, what's the rate and rhythm on this thing about? I heard 90 and I heard 56. That was interesting. This is a 10-second strip. It's a 10-second strip. And I'm going to tell you 56 is right on the money. 56 is dead on it, not 90. What you were doing was counting them all and multiplying it by 10. Instead, multiplying by 6. You won that one. Yes, I was right once. Okay, so they're going to die of that? As long as they got a pulse, no, right? As long as this isn't PEA. I want to tell you something. If this is PEA, stop doing a 12 lead. Okay, we should not be doing a 12 lead if this is PEA. All right, so assuming that they have a pulse with this, all right, then we need to think about just what where we're going next. So what were the steps? Anybody remember? Look for ST changes. Okay? Look for ST changes. See any? Any elevations?
No.
Any depressions?
No.
Okay. All right. Another quick question while I'm thinking of it. So you're just looking at your monitor, and you got a LifePak 15 or a 12, and you can see 3 leads on there, and they may or may not have elevation or depression. Does it mean anything if they have elevation in those leads? It does not. Not in elevation of ST segments. You need to do a 12 lead.
Right, but wouldn't that give you enough to tell you to go to
You might.
12 lead?
I'm okay with you doing a 12 lead based on that. I'm okay with it based on it, but seeing elevation in lead 2 does not tell me that there's definitely an MI.
No, and I'm not not saying that.
Okay.
I'm saying that.
I'm good with that. I say I should do a 12 lead.
Right.
I'm okay with that. Did you know that you can, so what that's called is a non-diagnostic mode. What you see on the screen is non-diagnostic mode. The only way we get diagnostic mode is to do a 12 lead. Okay? It's the only way. If I only have the 4 patches on, can I do a 12 lead? Can I double punch 12 lead and make it work? Yeah, you can. You can look at the first 6 leads simply by, now it really takes more than a double punch. A double punch will make it go, well, you're going to put in the age, and it does the age, and then you're going to put in if it's male or female, yeah, and then it goes, you're not all hooked up. I go, I know, do it anyway. And he goes, no, really, you're not hooked up. And you go, do it anyway. And after about that many pushes, it'll actually do a 12 lead, and it won't give you any measurements, but you will see a diagnostic of the first 6 leads. What's that tell me? Whether 2, 3, or AVF have anything in them, and if they do, I'm not giving nitro. Okay? Now I still need to do a 12 lead, but I know whether or not, I know when not to give nitro at this point. Okay? That's a thing. It's not the only way in the world to do it, it's just a thing. All right? Well, it is a little bit cheater's way, yes. So we're not seeing a whole lot there, are we? Is there any ST elevation, any depression? No. Got a sinus rhythm, there's a slight Brady. Do I need to fix that Brady?
What's blood pressure?
Ah, thank you for asking the question, what's the blood pressure? What's the rest of their vitals? Because I might need to if they constantly have a 80 for a heart rate, and this is way too low for them. I might have to. It would be rare that I have to do that, but I might have to. Okay, so you need to assess your patient before you make those kind of decisions. All right, so we're going to go with no STEMI here, okay? And we're going to start moving on. We're going to move quicker. You ready? Okay, now I can come back to here and look at all the answers to all that. The other thing I like about the LifePak 15s is they now start giving you ST elevations out on the right-hand side. Okay? That's sweet. That is nice. Don't just believe them, but I haven't found them to be very far off. Yes, sir. Oh, you're counting. Are you doing the 300 method? All right. So any of you do that? 300, 150, 175, so it's about 76, somewhere in there, 75, 76. Anybody do that? If you want to learn that one someday, we'll do it, but it takes a little while to sit down and do it. Okay? There's 300 big boxes in a minute. Okay? There's 300 big boxes in a minute. That's where that comes from. So this rate is actually 76. Is there any elevation or depression?
Yes, elevation.
Okay, where's the elevation?
I see it in B1, 2, 3, 4, and 4.
Yeah. Any depression?
I got depression in 1.
So these leads have elevation in them. What do we call them down here? Septal and anterior. You can call it an anterior septal MI, or you can just call it anterior, because V1, V2, if they're by themselves, it's going to be septal. If they are continued with the others, we can call them just anterior, V1, V2, V3, V4. When you're talking on the radio, talking about this stuff, don't say that I have elevation in 1 through 4, because they're going to go, well, you're nuts, number 1, because leads 1, 2, 3 are okay, but 4, there is no lead 4, okay? But there is V. There's V's, okay? Hey, who knows what the V stands for?
Vector.
Nope.
Ventricular.
Nope. It was a nice try. Those are great guesses. And there'll be some people who'll tell you that's right. It's not. It's all for unipolar. It stands for unipolar. It's from the Latin side of the world.
What's it for?
The V is for, it's all the unipolar leads. It stands for unipolar. So do we have a bundle branch block with this one?
Yes. I believe so. I'm way back here.
Okay. Who cares about a bundle branch block? Okay. So what does a bundle branch block do to leads V1 through V4 whenever you're doing a 12 lead if there's a bundle branch block? What does it do to them? Not necessarily negates it, but it sure makes me question it. It certainly makes me question it. We used to teach that if you've got a left bundle branch block, just forget it. Just treat the patient, okay? Because it's only important in certain circumstances. And he was looking for scarbosa, the word scarbosa, S-G-A-R-B-O-S-S-A. And I can read those qualifications to you, but basically what it comes down to is if I have a downward projected QRS in leads V1 through V4, there will be a false elevation up to 4 millimeters. If it goes above 4 millimeters, it goes to 5, it now meets the scarbosa criteria to say, oh, this is still an MI.
Right.
Do you want to try to remember that in the heat of battle?
And there's actually
And it's
three
got to be
different.
wide enough.
There's more. There's more.
Three scarbosa
Yes,
criteria.
there's more. So what do I really care about?
How the patient presenting.
That is over and over and over. Look at your patient, and what's the patient telling you? What are you finding out on that patient, okay? So you have to analyze that patient over and over and over. It's very important, all right? So in this case, they do not meet the scarbosa criteria. I can talk about scarbosa some other time. We're just going to say it does not meet the scarbosa criteria. And because of that, we're not going to call it a STEMI based on the EKG. They may still be having an MI. The other thing I don't know is if this is a new left bundle branch block, then the MI may be causing it. How's my patient presenting? Still important, okay? It's still all about that. How's the patient presenting? So I just kind of ignore that fact of the EKG to a certain degree, and I can tell the hospital what it's got, but it doesn't have to make a lot of treatment decisions for me. How is my patient presenting? Okay? So we'll go to this one. Got a little faster rate. Right off the bat, I can tell you the rate is almost close to 150, so it's about 140 because it's 2 big boxes, okay? 300 divided by however many big boxes you find. That's what your rate is, okay? And then you can break down each one in between too. That's why he knew to go to 140, all right? They're calling the rate 136. Really? Close enough. All right. Is there ST segment elevation? Where? 2, 3, and AVF. 2, 3, and AVF have ST segment elevation in them. I'm not going to tell you there's a whole lot there, but it is there. And you kind of have to look for it a little bit, but it does exist. Okay? Is there any depression? Not enough to talk about. There might be, they claim there is in AVL, but.
Gain so that I could see it.
Yeah, well, see, and there you go. That works too. Increase the gain. All right. So this one has an MI going on in 2-3 and AVL, or has elevation going on, and so we're going to call it a definite maybe on this patient. Okay? We're going to call that on. I know you don't have it right in front of you, so you can lay a piece of paper on it, and I get that. All right? But that's what we're working with today. Sorry. So here's their statement about it. It's a possible STEMI, inferior, borderline ST elevation in 2-3 and AVF. See how they said borderline elevation? So there's probably one square in each one. Is this patient based on, well, that's just exactly it. Are they going up? Or are they coming down? And that way, part of that, we can go back and look at the T waves, and they're kind of down, so it may not be early. I don't know.
Pretty good to say if you're getting called to the scene, it's going up.
When did your chest pain start? When did you start feeling funny? When did you go, okay? All right. All right. So, but we're gonna call it that. If you measure for LVH, for left ventricular hypertrophy in this one, it does not meet the criteria, if that crossed your mind at all. It may not have. Whoops, go back. All right, how about this one? Okay, so this is really cool here. This is where these come into shape. Okay, oh boy, the battery's about dying in this thing, I think. All right, look at it go down. So if you will look at the T waves, they look like somebody put a string in them and picked them up, right? That's the very early stages of an MI. That's the earliest stages of an MI. It just picked them up like a string, okay? That's also the ones with ST elevation, aren't they? See those? So if you see, you may get there so early that all you see is the T waves in that shape and not any elevation yet. Keep doing EKGs, or your monitor will do it for you. Have you ever had them where the monitor spit them out at you?
Oh, yeah, that's when you go.
You should pucker. You should pucker a little bit, okay?
You're talking to the patient,
Yeah.
oh, how's that pain?
Why does it stick? Why does it kick those out?
A change from the previous one.
It's a change in the ST segment elevations from the previous one. Whether it's up or down, there's a change. That's why it's kicking them out at you. So if there's a bunch of them out there, they're changing. Patient is changing. Pay attention. All right? What leads? What leads have elevation?
2, 3, 4, 5, 6,
Okay.
1,
V2 through 6,
AVL.
1 in AVL. And you'll see that he's reading those in kind of an order that makes sense to us now, because you've been doing it long enough, that you're doing them in an order that makes sense. 1 and AVL are both lateral leads. V5 and V6 are lateral leads, and V1 through V6 are all contiguous leads, but they go from the septal to the anterior to the lateral. Okay? And so you're reading exactly how I want you to read them. When you yeah, well, no. What now? Oh, you're getting me a new one.
Yeah, but tell me where you're going to plug this in at.
Well, I don't know.
Over there. Yeah, well.
So you have V2 through V6 with ST elevation, and V2 through V5 have T waves that are pointed. Okay? This is a very early sign, so we got a real good chance to get this person out of this thing with very little damage to their heart. Okay? And we also have 1 in AVL. So we have now, think about this. We have V1, 2, 3, 4, 5, 6 and AVL. We have the entire left side of the heart with an MI going on. What do we call that? The widowmaker. We do call it global. We also call it the
This person, their major
It's occluded very high. We got to get this fixed soon. Huh? High flow diesel? Yes, we can call it high flow diesel, and you make Dr. Brandt very happy with that. Treat him with diesel. You bet. And with aspirin. Aspirin and diesel. Those are two of the best things you can do for him. All right? Welcome back. And we also have reciprocal changes in 2, 3, and AVF, the other side of the teeter-totter. Okay? So this person's showing everything all over the place. And they have the Widowmaker going on, a global MI. All right. Let me see what the next one is. So we'll go to this one. What do you think of this one?
It looks nasty.
Okay. All right. What's their rate? Rate's right close to 100. No. It's just about 100. Okay. You think there's a bundle branch block going on? Okay, so let's talk about the bundle branch for just a minute. What things are required to make a bundle branch block? I don't care about right or left yet. What makes a bundle branch block? Width of the QRS has to be at least how much? 0.12. 0.120. Okay? 3 little boxes. Let's do 3 little boxes. What do you say about that? All right? All right, 3 little boxes, 0.120 or 120 milliseconds. Boy, don't you love the decimal system? Okay. All right, or metric system, I should say. Okay. So this is wide enough. What else does it have to be a bundle branch block? Say it again.
Rabbit ears.
No, it doesn't have to have rabbit ears. It might have rabbit ears, but it doesn't have to have rabbit ears.
It's got to be in the B leads.
It has to be a sinus rhythm. It has to be a rhythm above the AV node. Okay? So basically, we're saying it's a sinus rhythm. Could it be AFib? Sure. It needs to be from above the AV node. Okay? It can be an atrial rhythm. So you should be looking for P waves. You should be looking for width. Okay? And with those in place, I can now say this is a bundle branch block. Now I need to know if it's right or left. What's the easiest way to know that it's right or left? What's the way I've taught you before? I've taught you turn signals. There's rabbit ears too. Okay, but there's turn signals. Turn signals is the easiest way for this pea brain to learn about it. Okay? So you're going to look at V1 and you're going to grab your steering wheel. Get a hold of your steering wheel. Come on. Steering wheels. All right? You got a hold of your steering wheel and look at V1. Find the T wave. Find the T wave. If you can't see that far, you shouldn't be driving an ambulance. All right? So you find the T wave and move back into the QRS. Move back into the QRS, from the T wave into the QRS. And which way is the first deflection? Down. It's down. So if I move my blinker down, which way am I going to turn? Left. So this is a left bundle branch block because I'm looking at V1 to do that. All right? If instead it went up, I would push my blinker up and it would be a what block? A right bundle branch block. I don't know how much more simple you can get than that. I can remember that.
Clear as mud.
Clear as mud, okay? All right. Can there be rabbit ears? Absolutely. All right. So, on this one, we were talking about the Scarbosa criteria. Does it meet the Scarbosa criteria that you remember? This is 9, right? So the ST elevation of 5 millimeters or more meets the Scarbosa criteria by itself. All right? So you can see that it is more than, from this isoelectric line, it is more than one big square up to it. That's 5 millimeters. That's 5 little boxes.
But again, that's a case that you call the hospital, tell them, I'm coming in with Scarbosa criteria, positive.
They don't care. They don't care. Yeah, yeah. So that was the nice part about just sending it to them and telling them, giving them information about what you're seeing, rather than saying, I have an MI with, that is maybe an anterior MI that meets the Scarbosa criteria. They're not going to want to hear that, okay? Not very well, anyway. Most of them aren't. So we do meet that. Do we see any depression, ST depression?
Maybe in V5 and 6.
Yeah, I think there's some in V5 and 6, but we're not going to worry about it a whole lot. We've got enough here that it meets the Scarbosa criteria, so we're going to treat it like an MI. If it didn't meet the Scarbosa criteria, would I treat it like an MI? What made my decision about that? Look at your patient. What's your patient telling you? If your patient is sick, your patient's having chest discomfort, your patient's having any of the signs that tell us it's cardiac, then you should treat it like that. All right. Go to this one. I was running through these and I just chose some, so. All right. Can you fairly quickly make a decision that we ought to really pay attention to this one? All right. So tell me, what's the part of this that's got your attention? The inferior MI in 2, 3, and AVF. Anything else got your attention? So we are seeing some reciprocal changes, certainly in AVL. Look at V1 and V2. Look at V1 and V2. Maybe even V3, but V2 in particular. See, it's just a little bit depressed. So what else should we do to this patient, since we're doing this and we've got 15 minutes to get to the hospital? Now do a right-sided or a 15 lead. Do a 15 lead, yeah. And I don't care if it's just a 13, honestly, but do a 15 lead, all right? Do a 15, because you want to know before you give this patient any nitro, which is part of your protocol, right? Understood, but do your V4R. Be sure you get V4R in this. And go ahead and just do the, if you're going to do V4R, it doesn't take that much to do a 15. It takes 2 more patches. We're already blowing more patches. Just add them on. Put them in the back. It's easy enough. All right. What's the rate on this one? Let's see, 300, 150, 100, 75, about 75, 76. Okay? Well, it's actually 71, but according to them. But I got in the neighborhood of 75. Do you do the 300 method? Okay. So here's one that's right on the line. 300, 150, 175. And then it's one little square beyond that. Let's see. So they're saying it's another STEMI and that you need to be doing a V4R. All right, here's one for you. What do you think here? Rate and rhythm? Just sinus rhythm. 300, 150, 100, it's about 90. I gave it a rate of 90 just now. I don't know if that's right or not.
That's what I got.
Did you?
Yeah.
This says 82, good. I didn't hear you, I'm sorry. You were talking in my bad ear. Which is both of them, by the way. That's really I don't listen with them. I can hear, I just don't listen. All right. Any elevations? V1 has, if it's got a square, it's pushing it. This V2 and V3, though, I think have the elevation in them. I doubt that V4 does. But we'll agree on these two right here. Okay? And even though one is septal and one is anterior, they're still contiguous, so it still counts. Okay? Do we see any reciprocal changes? Not really, do we? So does that rule out an MI? It does not. Thank you. It does not rule out the MI. Okay. All right. So we're just going to keep moving here because there's what you can read about. They're calling this a septal. They actually go with 1, 2, and 3. V1, 2, and 3. Sorry. See? Don't even follow my own advice. V1, 2, and 3. No reciprocal changes does not rule it out. All right. Let's go to this one. This is why we're doing rate and rhythm. And they're a little bradycardic. Don't miss the bradycardia. Patients die with us looking at 12 leads, okay? Don't let them die reading the 12 lead. Not that that's necessarily knocking them down, but that may tell us part of what's going on with them. Okay? Probably what? Oh, okay. Yeah, yeah. They actually say 53, but I'm with you on the counting. So it depends which ones I think you look at a little bit. Yeah. Yeah. So could I count from here to here? No. Yes, I can. Because that's all one continuous time crunch across there.
I thought he had to be the same lead.
No, when you're looking at a 12 lead, the point of what I said before is this is one big long lead there. That's why whenever it has the fourth one going across the bottom, you'll see that it coordinates with every one of those. Just looking at the time across there, I can look at that. I can look at that. I just want to stop in the same place. Just be sure I stop in the same place, because one of them may have a QRS that goes up and one may go down. I just want to be sure I stop in the same place. That would be the problem with it, with doing it that way. But I just want you to understand this is one continuous time for this whole thing, okay? And so it's just looking at beat after beat after beat. It's just changing the view. The ones up and down are the same beat. All right? And I've seen 12 leads where they did all 12 leads on a piece of paper. That you'd see all 12 of them going across at the same time. All right. So, what do you think about where's the MI? Yeah. So I've got reciprocal changes. Probably V1 through 5. I go with that. Is there any others? Maybe there? I don't know. Let's see if they say that. They do not. They do not. Okay. All right. So, anterior septal, STEMI. You see where I'm going next? I must have turned the pages. There you go. How about this one? Rate and rhythm. The easiest way to look at that one's down here. What do you think? Have they got clear P waves? Are there some clear P waves? Yeah, there's some clear P waves. So here's P wave, here's P wave, here's P wave, here's P wave. Now remember, we're looking at V1. Will the P wave be upright or upside down? It's not a lead 2. That's what we learned how to read so much in, okay? This is V1.
I know you do this just to mess with us.
Yeah, well, yes, of course I do. Yes. All right. So it's really a sinus rhythm with PACs. Okay? I don't have a lot of heartache over the fact that you kind of look at it and go, from here it looks like a AFib. I don't care, because you're not holding this piece of paper in your hands, okay?
That person had too much Mountain Dew.
Too much Mountain Dew. And I thought it was a little faster rate if they did that. You see a STEMI anywhere? That's primarily why we're here. I'm not going to spend a lot of time on this because we're not, I mean, we could break this down more and more and more. We're not going to. Is there a STEMI? I didn't see one, did you? Okay. All right, here's this one.
Looks nasty.
Right side bundle branch block.
Yeah, look at that. He drove his car right into V1 and made a right-hand turn. Okay, that works.
He needs to go back to the driving course.
All right, so are you seeing any elevation anywhere? Are there any Q waves anywhere? Just look for Q waves. Do me a favor and just look for Q waves.
I can't see it. Well, maybe in V1, yeah, I might see them in V1, but they're very small. In your 10 seconds.
I'm sorry, how about here?
Yeah, maybe, looks like there's a downward deflection after.
So is there any upward reflection before the downward in this one? Is there any upward before the downward in this one?
Yeah, a little bit, right there.
No. That's the P wave. Don't count the P wave. Of the QRS, is there any upward deflection in the QRS? You were counting the P wave. Is there any? No. There's really not. And so that's a Q wave. This one, if you could see it closer, you can't see it close enough, I realize that. That has a Q wave in it. That means, and this one over here definitely has a Q wave in it. We're going to definitely give it to 3 and 4.
If you go down the
That means there's an MI there. Is it a STEMI? Well, we don't know because we don't know when it occurred.
I thought it's a past Q.
Well, it might be. We don't know how past. Is it an hour past, 2 hours past? Is it days, weeks, or months past? That's what we don't know. You're correct.
That's where you would ask your patient,
Have you had this in the past, and how long ago did your chest pain start? How long did you feel funny a while ago? Yeah. Yep. You're exactly right. Going right back into that. But there is this bundle branch block in there as well. Okay. The other fun thing about this right bundle here is if you will look in the lateral leads. I want you to think about the lateral leads now. So I'm looking from over here, right, from the left side to the right. If the block is on the right side, The left side will work just fine. So I see an upward QRS that's normal, and then there's a downward swoop. You got this big wide S wave on the bottom in the lateral leads, only in the lateral leads. See that big S wave up there in the lateral leads? That's the fun part of looking at it. The nurse showed me that one day. She goes, we were not looking at V1. We had not done a 12. And she goes, oh, look, a right bundle branch block. I went, whoa, stop. How did you know that? She goes, this big swoopy S wave down here. Okay? And there's a big swoopy S wave here because it's moving away, and anything moving away is a downward, and it's moving away slowly. Cool. I'm good with 2. Are we done? Okay. All right. Are your brains done? Okay. Okay.
Whenever you're finished,
All right. I'm having. I've only got about 30 more to go.
You're done, sir.
Okay, so we didn't speed read very fast. I'm sorry.
but you did wonderful.
Is this okay? All right. Thank you. He's not. You have any questions? Do you have a burning question you want answered?